Hi guys, welcome back. We shall now be talking about raised intracranial pressure. The etiology can range from a brain tumor to a head injury patient or to a possible patient of intracranial hemorrhage or stroke. So I will explain to you regarding what are the etiologies behind it and what are the presentations. But first of all, we should know what do you mean by the word raised intracranial pressure. Now, all of you are aware that the normal pressure is between in the ventricles 10 to 20 millimeters of mercury. So we will say the word raised intracranial pressure that will require management or treatment is when a value is more than 25 millimeter of mercury for a duration that exceeds more than 5 minutes. Do remember the fact he can even ask you regarding what are the goals of treatment. The goals of the treatment would be that the pressure in the ventricles should be kept below 20 millimeter of mercury and cerebral perfusion pressure. I'll explain the meaning of the word cerebral perfusion pressure in a few seconds from now, but the cerebral perfusion pressure should be kept at a value more than 60 mm. So I repeat the statement once again. I am going to intervene when the values are more than 25 for 5 minutes, and my objective is to maintain a CPP of at least 60 millimeters of mercury with a pressure obviously of less than 20. Well, what do you mean by cerebral perfusion pressure is the difference between the mean arterial pressure and the intracranial pressure. Mean arterial pressure can be calculated by this simple formula in physiology. You all know about it: systolic plus 2 times diastolic, and then the whole value is divided by 3. So if I put in the values of 120 by 80, the mean arterial pressure for you and me is approx 95 millimeter. Intracranial pressure is approx 20 millimeter mercury on the higher side. So cerebral perfusion pressure for you and me while we are sitting comfortably and discussing this topic is about 75 mm. Now, nothing is a constant value in internal medicine, so it's always a range. So the range is 60 to 80 millimeters of mercury. I basically want to explain to you the fact that if the values of this perfusion pressure are less than 60, you can have a brain infarction. And if this pressure becomes more than 80, then there's a possibility that a blood vessel can pop off and can burst and can cause a hemorrhage. We survive in this narrow window. Anything less than 60, anything more than 80 can be detrimental to the life of a person. So let us now see what are we going to do in a person who's having a brain herniation, who's going to have a raised ICP. You can see the diagram here for brain herniation. I'll be explaining the different types of brain herniation to you guys, but I can just put up a straightforward question because I presume you have studied neurosurgery. Can you tell me which is the commonest type of brain herniation? Well, if you have studied the surgeon's notes, you will notice, in fact, most surgeons say that. I will contradict him. That is why I am saying it right away. The most common type of brain herniation, and I'm giving a reference of Harrison, 20th edition, the most common type of brain herniation is transtentorial herniation. Now, what is the controversy? You might be wondering that I'm talking about a surgeon's name, a surgeon, and then I'm saying, okay, surgeons will not say this. This is because of the fact that in some surgical books, it is mentioned as subfalcine herniation. I would like to highlight that when I was a student at your age, even I used to study subfalcine herniation as the commonest type. But currently they have shown and documented, and that is what the 20th edition of Harrison is saying. So I'm just putting it in this fashion that if you get a question where both are given, your primary answer is going to be transtentorial herniation, where the brain sinks downwards and therefore the vital centers of the brain are compromised. What do you mean by subfalcine herniation? Though we'll talk about this a little later also, but I will just zoom in and say subfalcine would mean that you can see like this is one of the gyrae and sulci present here. So this part will basically herniate beneath the other. That is a horizontal shift. Now I can just use an English word here and you can relate to this. The word is midline shift. Lots of time you would have seen CT scans or MRIs that might be saying this word midline shift documented. So what do you mean by the word midline shift? In English, the technical word is subfalcine herniation. That is one part of the brain moves horizontally. Now, what they've done in studies is that they documented the fact that this subfalcine part, midline shift thing, this is less documented as compared to transtentorial herniation. So, to cap the controversy, I would just like to state the fact that if they ask you what is the most commonest type of brain herniation, it is going to be answered as transtentorial. And the reason why I'm so worried is because if it occurs downwards, it will compress the brainstem. You see, can you tell me the pacemaker of the respiratory center, guys? You all know the pacemaker of the respiratory center is pre-Botzinger complex. So if you crush the pre-Butzinger complex, the person won't be able to breathe. There would be lack of respiratory drive. The person will develop a apnea and can expire. So raised SAT can contribute to cardiorespiratory compromise. Why cardio? Because vasomotor center will also be compressed. So in raised SAT, the danger is that there would be crushing of the brainstem. The vasomotor center is compromised. The respiratory center is compromised. So the BP can crash and the respiratory drive will also crash. That can contribute to expiry of the person. Now, what am I going to do not to allow this to happen? Then, well, I can start with drugs. And what drugs would I start with? I will start with osmotherapy. In fact, the first thing that is given in the notes for management of this person is osmotherapy. We can give mannitol, or we can give glycerol, we can give acetazolamide, the standard drugs. I would like to highlight the fact that from the pharmacological perspective, like if he says that what is the first thing to be done, then agreed osmotherapy. But wherever possible, like if I have a person of raised ICP, what would I would like to do? I would like to, from nursing perspective, position the patient. Remember my words there. In the notes, I have written osmotherapy first because that is what you do as a doctor, right? I mean, you start the person on medication. But from the nursing perspective, I want to highlight the fact that lots of time you will notice that in our government hospitals, basic nursing rules are not followed. Lot of head injury patients will be kept in supine position, which is not the case. Rather, the head end of the person should be slightly elevated. Now, when I say that, again, I get a query from a lot of doctors saying, "Sir, how is it possible? I mean, you were saying a head injury patient will be kept, slightly propped up with head slightly elevated. Will that not increase the chances of brain herniation? Will it not cause the brainstem to be compressed?" No. Setting position, say what it does is, right? What it does is that it improves the jugular venous outflow. I'll say a formula. Perfusion of any organ is a difference of arterial pressure minus venous pressure. So if the blood is going to flow out, if the blood is going to flow out, the venous outflow will increase, the perfusion will automatically increase. See, perfusion is A minus V. Arterial pressure minus venous pressure. If the venous outflow will increase, the venous pressure will reduce. So mathematically, the perfusion of the brain will increase. And even if you don't get into this, I just want you to remember the fact that when you come on the scene, you obviously have to start drugs. As a doctor, what are you supposed to do? Give medications. But you must remember that there should be a slight head and elevation of all patients of raised ICT. From the treatment perspective, what are you going to do? You want to give mannitol to the patient now, because that is very, very easy and anybody and everybody can answer it. In the exam, he did not have mannitol in the options. Rather, you will put the tick mark on 3% select. Please remember the fact that osmotherapy implies you are giving something concentrated that will remove water from the brain, that will reduce the swelling in the brain. So mannitol is good enough. You can use 3% saline for the patient, but do not use hypotonic solutions. Right at the outset, I want to tell you that 5% dextrose is contraindicated in persons of stroke having raised ICT, brain tumor having raised ICT, any etiology of raised ICT. Do not give 5% dextrose. This is a straightforward statement given in the current edition of Harrison, that hypotonic, it has been given in all the editions of Harrison, in fact, that we do not give hypotonic fluids. They are absolutely contraindicated. We give concentrated solutions. So we give mannitol, we can give 3% saline, and the patient will improve. We do have IV preparations of acetazolamide as well, though acetazolamide will not act immediately, but yeah, at least we are having it at our disposal. And we also have glycerol available. You see, why we give glycerol is, like I can say, like you would have seen a lot of patients of tubercular meningitis in your pediatric wards. Now, those patients of tubercular meningitis in the pediatric ward, the child has been admitted for almost like 1 week, 2 week, to because of that repeated, cannulation. Almost all the veins are suffering from thrombophlebitis. Lots of time in pediatric units, because you see in children anyway the veins are smaller, the chances of thrombophlebitis is anyway higher, because you do repeated cannulation. By the end of 1 week, or let me say 10 days, the mother, when you go to the bedside to put a cannula as an intern, no, the mother is like, doc, where are you going to find the vein? There's no vein, right? because of the thrombophlebitis component. So there is no need to poke the child again to give mannitol if he's having a raised SAT, because TBM, if the raised SAT part would be long standing part, right? Because even if you give ATT, it's going to take a long time to resolve. So you will notice that in those unconscious children with tubercular meningitis with raised SAT, what do? We put in an NG tube and we ask the nurse to teach the mother to give glycerol to the patient. Though it's a little risky, that she might give something and that might, the tube might be dislodged and that might cause a aspiration. But then, okay, I mean, we gradually have to send the patient back home because the limited beds in our hospital. So for management of raised SAT, osmotherapy is the way forward. These are the two main things that you will use in emergency settings. And for conditions like normal pressure hydrocephalus, that is will be discussed subsequently, we can use acetazolamide, or we can use for tubercular meningitis with raised SAT on a long-term basis via nasogastric tube glycerol. Now, the basic point is that this may or may not be very effective, because suppose a patient came right now, he has had maybe a brain hemorrhage, and unfortunately, though you given mannitol, this particular person is having a posturing. To explain the posturing part, I'll put it like this: like in the hospital, you are noticing the following position of the patient. The legs of the person are extended, but in the arms and at the wrist joint, there is a flexion present. This kind of a presentation highlights the fact that the brain herniation process is going on, and we are going to call it decorticate posturing. This is a bad sign. This is bad news because you could lose the patient. So my question to you guys is, you are having a person with either a head injury, surgical case, or a medical case of brain hemorrhage, intraparenchymal hemorrhage with posturing coming into the casualty right now. He's having this positioning of the body. What step would you take to reduce the pressure in the brain? Because otherwise he's going to expire right before your eyes. There will be brain death. Okay, while you are waiting for an answer, I can say the fact where while you're thinking about an answer, what I can say is, you will notice that in some cases the positioning might change, and now the same chap may not be having flexion in the arms, but he might be having an extension. This positioning where there is extension both in the arms of the person as well as in the legs of the person is what is called as decerebrate posturing. So what I want to tell you is, one, that if any of these two are occurring in your patient, it is really a bad news. You need to act fast. And what are you going to do? I want an answer now from you while I show you these two images once again. That is, you can have first a decorticate posturing and then a decerebrate posturing, or can be written as decerebrate rigidity. You will notice that there would be extension in the arms with the pronation of the arms and then a slight flexion here. You please notice the fact that subsequently it's always a flexion at the elbow and flexion here also. But later on there is a extension at the area where I had shown flexion earlier. There is a change, there is extension. The arm is pronated, and then there is a flexion anyway continuing. So you need to, one, remember this for image based questions, and the question is still open. What are you gonna do? So what are you going to do for this chap is go in for a procedure known as ventriculostomy. I would like to highlight the fact that most of the time as interns or as internal medicine residents, we do not know ourselves to do a ventriculostomy procedure. So you will have to call in a neurosurgeon. But if you're planning to do private practice of your own, then ventriculostomy is a procedure that should be learned, because in your nursing home, a lot of head injury patients will come, and you would lose your patients right in front of you, because by the time you refer to a tertiary care center, patient will lose. So what I'm saying is, if you plan to open a nursing home of your own, then I think as an owner, as an entrepreneur, you should obviously have a skill to run a nursing home, but at the same time you should also have the technical skill to learn and go ahead with the procedure of ventriculostomy. And a resident in a neurosurgery would be, maybe a senior person would be happy to teach you. So let us now talk about what do you mean by the word ventriculostomy, and I would also like to highlight the fact here that this is the most effective method overall. For if you can do this procedure, it's very sure that your person is not gonna herniate right before you. In ventriculostomy, we are gonna put a. In fact, I can just show an image for this also, so that you can relate to it relatively better. The ventriculostomy procedure. Yes, look at this image. What are we doing? We are putting in a catheter. We are drilling a hole on the top of the head of the person, and we're drilling in a catheter here, and we're placing the catheter in the lateral ventricle. When I put this catheter here, this catheter This is an intracranial pressure monitoring catheter. It will have a sensor at the tip. This sensor will record that the pressure is definitely more than 25 millimeters of mercury, and at the same time, on a digital display, it will show to you also what is the pressure in the brain, so you can actually see on the digital display. The sensor will record at the tip of this catheter is the sensor that will record the pressure, and this sensor is then connected to a one-way valve. Inside this catheter is a one-way valve. The one-way valve will open. I repeat the statement once again. The sensor is connected to a one-way valve. The moment the one-way valve will open, the CSF of the person will flow out, and therefore it will ease off the pressure. If you look at this diagrammatic representation, you can understand that if a person is having a raised ICT, then these ventricles would be relatively dilated. And the more is the dilatation of the ventricles from inside, they will press on the vital centers, and due to gravity, obviously the lower part of the brain can be affected first. So I don't want that to happen. So I'm going to put in an intracranial pressure monitoring catheter, remove some CSF. And when I say remove CSF, the query of most doctors is that if you will remove the CSF, won't the structure collapse? Please appreciate that we are having a continuous production of CSF. No, you are all aware from basic sciences that choroid plexus is the site for synthesis of CSF. Choroid plexus is the site for CSF synthesis, and CSF is produced at a rate of 20 ml per hour. So even if you remove a few ml, it will not cause a problem. And don't worry about how much ml you need to remove, because this is a fully automated system. So you don't need to calibrate and calculate all the time that, okay, this much is the pressure in the brain, so this much ml of CSF I need to remove. This is a fully automated system that will remove the CSF and will ease off the pressure and will cause a dramatic improvement in chances of survival. The CSF will flow out into a sterile container. Again, more will be produced. Again, it will flow out. You are all aware of the fact that CSF is synthesized at the choroid plexus at a rate of 20 ml per hour. I'll put up two questions before you. Can you tell me the rate of CSF reabsorption? Production is 20 ml, reabsorption. The rate of CSF absorption is again 20 ml per hour. Please appreciate that the rate of production and rate of reabsorption are equal. That is why the pressure is constant. I repeat that again. The rate of production and the rate of reabsorption is equal. That is why the pressure in the brain is constant. If you have an imbalance between the two, either the production should be more or the reabsorption part should be slow. Like for example, I can say, suppose a person is having subrectal hemorrhage. That subrectal hemorrhage can cause an obstructive hydrocephalus. It can obstruct the flow of the ventricle. So subrectal hemorrhage also has raised SAT because it obstructs the flow of CSF. So in any of the two, either synthesis can be more or reabsorption can be less. The pressure will begin to rise. You're all aware that the site of reabsorption would be subarachnoid space. I just wanted to highlight to you that why do you have raised ICT even in subarachnoid hemorrhage? After all, the blood is in the meninges, because that bleed actually obstructs the flow. It subsequently causes an obstructive hydrocephalus. In tubercular meningitis, the pus is very thick. The pus blocks the outflow of the CSF. Again, the pressure would rise. So it's not only a case of stroke or brain tumor that would come to you with raised ICT. It would obviously be tubercular meningitis patients. It could be, pediatric cases of tubercular meningitis definitely on. It could be a person having meningitis encephalitis, because why? Meningitis encephalitis will irritate the choroid plexus and cause more production of CSF. So in meningitis, why do you have more raised ICT, or the ICTs increases because of the irritation of the choroid plexus by a bacteria or maybe a virus. So ventriculostomy is not for meningitis encephalitis. There the increased pressure can be managed by drugs only. But I am saying that if a person, when are you going to do a posturing like this? When are you going to do a ventriculostomy? Only when the person is having a impending brain herniation. And how do you know as a doctor? Well, one is that there is a posturing occurring in a patient. Please appreciate that if it was a case of subdural hemorrhage or extradural hemorrhage having a posturing, I would have gone in for a burr hole. Right, I have explained that in my earlier discussions that if a person is having a presence of extradural subdural, we do go for a burr hole. But here I'm talking over generalized discussion of causes of raised ICT, because raised ICT can be seen with multiple reasons. So if, like, let me say, in a case of head injury, you are not able to manage with osmotherapy, and it's, let me say, an intraparenchymal hemorrhage for that matter, because trauma can also cause intraparenchymal hemorrhage, not necessarily only extradural subdural. So you can go in for a ventriculostomy, and this is a very highly effective method for management. Now here from pharmacology perspective, I would like to highlight the fact that do not answer steroids. For cases of head injury, they are not effective. Glucocorticoids are to be answered for only a person having vasogenic cerebral edema. You see, there are two types of cerebral edema, no? Cytotoxic cerebral edema and vasogenic cerebral edema. Glucocorticoids are not useful for cytotoxic cerebral edema. They are useful in vasogenic cerebral edema. One example of a condition where I have described vasogenic cerebral edema is neurocysticercosis. So we can give steroids. Another cause where we can, have vasogenic cerebral edema is high altitude cerebral edema. That is, high altitude pulmonary edema and high altitude cerebral edema have been discussed together in emergency medicine. When it comes to cytotoxic cerebral edema, though do study about how to differentiate between them on radiological perspective, I'll also try to do that. Do remember cytotoxic cerebral edema is the one that is seen in stroke. Cytotoxic cerebral edema is the one that would be seen in a case of a head injury. In these two causes, the treatment for cytotoxic cerebral edema would be to go in for osmotherapy. Do remember the statement of mine, steroids are not useful in stroke and head injury because they don't work. They are rather useful for patients who are having vasogenic cerebral edema. Examples have been mentioned here. In fact, one of the features of cytotoxic cerebral edema, which I would like to highlight here from a radiological perspective, would be loss of gray matter and white matter differentiation. I mean, normally on a CT, you can definitely see that, okay, this is gray matter, this is white matter. But after stroke, one of the radiological findings that you will always see written, even in a stroke patient, even if you don't have a well-defined hypodensity after ischemic stroke, this word will always be written in most reports of ischemic stroke that you will see. Loss of gray matter, white matter differentiation. That tells you it's a cytotoxic cerebral edema. So we are not going to use steroids for the person, which you can remember. This is the point. Now let us assume that a doctor does not know how to do ventricular. You have never learned it because you never were posted to neurosurgery and you never bothered to listen. I mean, never bothered to learn the procedure. So in those circumstances, lots of time in internal medicine units, this is what we do. We will sedate the patient and put him on neuromuscular paralysis. Now, why is it important to sedate the patient and put him on neuromuscular paralysis is because after a raised SAT will cause coma. Coma is a condition where a person cannot take care of his airway. He cannot swallow his own saliva. So comatose patients are prone to the risk of aspiration. Not only that you're going to make them drink something and they're going to aspirate, even their own saliva can go in the lungs and you could be having a pneumonia. That too anaerobic pneumonia. Because the organisms in the oral cavity are anaerobic, no? So it could be anaerobic pneumonia where you will have to use clindamycin. So in a comatose patient of raised SAT, I can sedate the patient. What are the drugs I can use for sedation? I can be using midazolam. I can be using propofol. And then I can be using even morphine as a last resort if I don't have anything else. Yes, looks a little surprising, but he has written regarding the use of morphine as well in persons of raised SAT. But primary answer is midazolam only. I mean, for extreme situations, he has mentioned it, but it is given in the book. For neuromuscular paralysis, you can use any drugs like pancuronium or vecuronium, atracurium, or you can use succinylcholine. So you can achieve neuromuscular paralysis in a patient. And now what you will do is you will electively intubate the person. After you've intubated, you will put the patient on positive pressure ventilation. So the steps are sedate the person, achieve a neuromuscular paralysis, and then intubate. Hook him onto a ventilator, and now you will deliberately on the dashboard of the ventilator keep the respiratory rate on the higher side. Why on the higher side? Because this will cause carbon dioxide washout. What is the advantage of carbon dioxide washout? The advantage is that it decreases, mark my words there, read my lips. The carbon dioxide washout is gonna decrease the rate of CSF production, and if you reduce the rate of CSF production, then the pressure will automatically come down. So I repeat once again, you can lower the raised intracranial pressure of the patient by decreasing the rate of CSF production from, let me say, 20 ml per hour to 15 ml per hour, because less volume means less space and less space means less pressure. So I can downgrade the raised SAT by going in for what I've explained in point number 5 as elective hyperventilation. You see, we started with something as simple as osmotherapy and positioning the patient. Your nurse will do positioning, you will give osmotherapy, but ultimately, what you are doing is elective hyperventilation. Elective hyperventilation cannot be used for long duration. It is okay for short duration. Like right now, the person is having posturing. So for short duration, at least I can buy some time for the person before a definitive procedure can be done. So elective hyperventilation is a short-term method to reduce the pressure in the brain. It is highly effective. I repeat the statement again. It is highly effective, but it is only for short duration. So in a question, if you have to compare between ventriculostomy and elective hyperventilation, I repeat again, if in a question you have to say which is most effective you compare ventriculostomy procedure versus elective hyperventilation, then ventriculostomy is more effective. So I can just put in the word most effective here for ventriculostomy. The most effective word is also written. Remember my words again. The most effective word is also given for elective hyperventilation, but he has put a rider. He said only on a short term basis, because if you look at the steps in the algorithm, he first says ventriculostomy, then says elective hyperventilation. So obviously all steps have to be highly effective for something to be included in the algorithm for management of raised SAT in a textbook like Harrison. It has to be highly effective. Now when we are putting numbers there, like which is second, which is third, which is fourth, he says the fact that depending on the facilities, like for example, let me say neurosurgeon is not available and I myself do not know how to do ventriculostomy, so what will I do? I will do straight away elective hyperventilation. But if I'm having all the facilities in my hospital and ventriculostomy procedure is possible, then I will first do ventriculostomy. So the learning for you is that you can shuffle this order. You can shuffle this order depending upon, he's mentioned this categorically, that all these steps for management raise SAT, you can shuffle it depending on the availability. But if everything is available, then obviously you need to follow the protocol. No, so ventriculostomy comes first, and on a short-term basis, a highly effective method is elective hyperventilation. Let me say that because it's a short duration method, you will anyway have to think of something extra beyond this also. So let us just use that mathematics once again. Remember and just follow my words. I stop noting at the moment and just listen to the words I say. I had taught you about this formula right in the beginning, that cerebral perfusion pressure is a difference of mean arterial pressure and intracranial pressure. Mean arterial pressure is approximately 95 millimeter of mercury. Intracranial pressure is about 20 millimeters of mercury. This is the values that I told you. Let me write this again. Please don't note it down. Just follow my mathematics here. It's purely a mathematical domain. Now, suppose intracranial pressure is rising. The moment the pressure will rise, what will happen to cerebral perfusion pressure? It will decrease. I, as a doctor, will not allow this to happen. How can I prevent that? I can increase the mean arterial pressure of the patient. Keep your eyes on the board. If I will increase the mean arterial pressure, then this mean arterial pressure will counterbalance the increased intracranial pressure of the patient. I repeat the statement once again. If intracranial pressure rises by 5 points, if I increase the MAP also by 5 points, then both will counterbalance each other and the cerebral perfusion pressure can be maintained. So to ensure that the mean arterial pressure is increased, what I will do in point number 6 will be go in for vasopressors, pressor therapy. You might be wondering that I am talking about dopamine infusion in head injury case. Yes, dopamine is used in cardiogenic shock. True. Dopamine is used in septic shock. True. But I'm teaching you dopamine is used in head injury too. True. Dopamine can be used, phenylephrine can be used, norepinephrine drip can be used. The standard vasopressors which are available can be used here. I can just make you practice this fact. Dopamine is preferred drug to be used in cardiogenic shock. Absolutely yes. It is used in septic shock. Absolutely yes. It is also, the word is also used in patients of raised ICP. Why? Because it will increase the mean arterial pressure, and by increasing the mean arterial pressure, it will counterbalance the raised ICP of the person. So therefore, there are three important uses of dopamine that I've taught you: cardiogenic shock, septic shock, and raised ICP. And pressor therapy is therefore useful for our patients. So these are the steps that I want you to remember, and you can obviously shuffle these steps depending on the availability. I mean, it's not that pressor therapy has to be given later. It can be given given even before the intubation part. No, like suppose I decided to intubate a person. Now, since COVID-19 is going on, so we have very strict protocols for intubation. So I need proper face shield, I need protection. Now, by the time that protection and everything is available, what will I do? I will start at least pressure therapy. Like, you are posted in casualty, COVID is going on, you know that intubation is a aerosol generating procedure. I'm having only an N95 mask. I'm not having a PPE, I'm not having proper protection. So I'll not let the head injury patient die, just because I can't intubate him right now. I need protection, but okay, fine, at least I can give him pressure therapy. So you can juggle the steps, you can shuffle the steps. So there's a possibility that in the notes, pressure therapy can be given before, because there's a possibility of shuffling also available. But this is the usual protocol that we use for management of these persons. Now, assuming the fact that you have done everything that I have said here, I'll just say the facts once again. You position the patient, osmotherapy. I mean, head and to nurse will herself do, don't need to worry about it. The osmotherapy component, ventriculostomy, sedated the patient. You've not given steroids, you put him on elective hyperventilation. Remember my words, elective hyperventilation is effective for shorter duration. On a longer duration, ventriculostomy will be more successful. So you've done everything possible here, but still the person is not improving. The pressure is still increased. What would you do? You will go in for what is technically called as tier 2 therapy. Till now, I have taught you 6 points for management of raised ascites. In 6 points, at least 5 were interventions. Fourth point was steroids. They're not given, so that's not an intervention. That's just to take care that you don't give the wrong treatment. But then interventions I've taught you are at least 5 interventions I've told you. I'll say them again. Grossly positioning, then osmotherapy, then vasopressor support, then elective hyperventilation. That is only for short duration, as I highlighted before you, and sedation part, right? So you can definitely do interventions, and you can reduce the pressure in the brain. But suppose it is not reducing, what would you do? Tier 2 therapy. So in tier 2 therapy, I'll just look at the points. Yes, that's the 7th point of our discussion. In tier 2 therapy, what we will do is we will go in for a medically induced coma. What I mean by medically induced coma is we shall be giving pentobarbital coma to the patient. And while explaining this medically induced coma, I can give example of about 3 years ago, the ISIS, the Islamic State organization, the terrorist organization, they had planted a bomb at the Brussels airport. Brussels in Europe is one of the busy airports which connects both America to Europe and Europe to India. So they had placed a suitcase with a bomb in the check-in area. And when this bomb went off, then unluckily there was this girl from Mumbai. She was working with Jet Airways, which had a counter there at the Brussels airport. When the bomb went off, the shockwave of the bomb caused damage to the brain of this young girl from Mumbai, and it caused a head injury. This girl was admitted in the Brussels hospital, and they treated her with everything that I've discussed with you, intubated her, did elective hyperventilation, then performed a ventriculostomy procedure, but the pressure in the brain was not coming down. So she was put on pentobarbital coma. Why? Because it has been documented that barbiturates are cerebroprotective. Even the pharmacologist would have used this word, that barbiturates are cerebroprotective. How? Barbiturates reduce the metabolism of neurons. Listen to my words carefully, because pharmacologists will only say cerebroprotective. How are they cerebroprotective? Because they decrease the metabolism of neurons. If you decrease the metabolism of neurons, it will then cause a decrease in energy requirement of the cell. And if you decrease the energy requirement of the cell, then the cell can survive for relatively a longer duration. The longevity part is increased. I repeat once again, if you reduce the metabolism of neurons, if you decrease the energy requirement of a cell, then the chances of survival of the cell, that is the longevity part, is definitely increased. Because of this technical aspects, barbiturates are taught in pharmacology as cerebroprotective. This is the reason why pentobarbital coma is used in persons of raised ascites in tier 2 therapy. This girl from Mumbai, she was in medically induced coma for almost 1 month. She came out of this coma, and then finally, well, she resumed her duties back in Jet Airways. And I want to tell you that in India, head injury patients, they have such a bad prognosis. You would have seen so many of your patients dying because half the time we are not doing all these things. Why? Because we don't have facilities. So government of India does not care about doctors, it does not care about health infrastructure, so they've not provided us with anything for us to be able to try and save a life. Otherwise, I mean, we do have methods available and we're studying with them. For the next method, I want to tell you that I can, in fact, if you are into sports, guys, if you're listening to me especially, you would have read about Formula One racing, and especially you would have read about a Formula One driver. In fact, I can name two. One was a Formula One driver when I was at your age. His name was Ayrton Senna. Ayrton Senna, he was a Brazilian, and he had a very nasty crash. And the steering wheel impacted his chest, and he had a cardiac tamponade, and he died because of that. So if you just type the word Ayrton, Aryton, Ayrton Senna, Brazil, from Brazil, and he was a Grand Prix champion. He had a nasty crash. The steering wheel went in the chest, and that caused a cardiac tamponade. And I have described such a scenario in cardiology. Then I want to take the name of Michael Schumacher. Michael Schumacher had a very bad crash. He was a Grand Prix champion for 10 consecutive races. I mean, that's difficult in Formula One because obviously you need a lot of skill. But this chap, he had a bad crash. His helmet was damaged to the level that he had a severe head injury. But it's been so many years since that accident. He's totally bedridden. He can't talk. He can't walk. He'll never recover. He's maybe 30 kgs weight because of malnutrition setting in. But still, he's alive. How have the Americans managed to save their, I mean, how did the American medical tech fraternity manage to save this ace Formula One driver after suffering from an extreme head injury? When in India, we routinely have head injury casualties, is because they decided to use this technique, which was experimental earlier, but now is a FDA approved technique, that is therapeutic hypothermia. In therapeutic hypothermia, you are basically cooling down the temperature of the brain of the patient, especially. So temperature of the brain is lowered to about 33 degrees Celsius. And the advantage of why do you want to lower the temperature is, again, that this will reduce the metabolism. Even temperature, I mean, if you reduce the temperature of any cell, you know that from, let's apply physiology here. If you reduce the temperature of any cell, then the energy requirements will go down. And if you decrease the energy requirement of any cell, then definitely, I mean, the cell will be able to survive for longer duration. So do remember my statement that therapeutic hypothermia is a definitive FDA approved technique, tier 2 therapy for management of raised ascites. And I have shown this image because, you see, if we were seeing a doctor or a nurse putting some kind of compressions over, or some kind of these kind same kind of device, no, bladder devices over the calf of the patient, then those are called as compression stockings. Compression stockings are put for preventing deep vein thrombosis. There has been an image-based question for a doctor putting these kind of these kinds of bladders over the calf muscles of the patient. That is compression stocking for prevention of deep vein thrombosis. But here you can see we are putting it over the thighs, over the abdomen, over the chest of the person. That is therapeutic hypothermia is being trying to be. We are using cooler packs, and nowadays we have technology to cool the blood also. We can directly take a vascular access of an artery. We can take a vascular access of an artery and use special pads to cool the blood. The objective is to decrease the metabolism of the neurons. And I want you to remember that therapeutic hypothermia or targeted temperature management is also useful in cardiac arrest. Let's just make an entry here. Therapeutic hypothermia is not only used in patients of raised ascites, but is also used to improve survival in patients who have undergone cardiac arrest. If you will listen to the ACLS discussion of mine, I have used the word targeted temperature management. I highlight the fact targeted, in fact, I can just write the word so that you can remember it. Targeted temperature management simply means that if you will reduce the body temperature, especially of the brain or of the heart, then the stress on them will also become lesser, because all cells will have reduced requirements, and therefore the heart will have to work lesser, the brain will have to work lesser, so the chances of survival will increase. So therapeutic hypothermia is a FDA approved technique. Point number 9 is optional if you want to note it down. And you all know this from surgery that we can also go in for decompressive hemicraniectomy. Out of 7, 8 and 9, if you ask me the effectiveness, then the most effective is decompressive hemicraniectomy. Why? Because you're removing the half part of the skull, so you're easing of the pressure. The remaining two techniques are not experimental. I am not teaching you anything of experimental science here. I'm teaching you what is exactly given in the textbook, what is given in Harrison. So these are methods of decreasing the pressure in the brain that I want you to remember. And raise SAT per se is a topic which you should know not only from the exam perspective, but generally also you should know what are the interventions that are available. So what are you gonna do? Let's do a quick recap. Osmotherapy. However, the person is beginning to have posturing, you need to be more aggressive. What you can do a ventriculostomy. Suppose you have never learned the ventriculostomy procedure, neurosurgeon is not available. What will you do? Elective hyperventilation. But before hyperventilation, what is important? Sedate, achieve neuromuscular paralysis, because I don't want the patient to be fighting when you are putting an endotracheal tube. Comatose patients do not have a secured airway. So ensure proper sedation, ensure proper neuromuscular paralysis, then intubate and deliberately keep the respiratory rate on the higher side to cause a carbon dioxide washout. Now suppose this is gonna take time. I am gonna anyway start dopamine drip in the person because I wanna attain at least a normal CPP of more than 60 to ensure survival. And if this is not working, then obviously pentobarbital coma, therapeutic hypothermia, and the surgical management or decompressive hemicoronectomy are methods by which pressure in the brain can be reduced. So let us quickly now revise regarding the clinical features that can be encountered in patients having a raised intracranial pressure. I'll remind you the values of more than 25 millimeters of mercury for more than 5 minutes is raised SAT. That's when intervention is to be done. One of the standard features that will always come will be headache. Well, you can understand the reason for headache is that the pain sensitive structure in the brain is the dura mater. So when the pressure in the brain will rise, it will cause stretching of the pain sensitive structure, that is dura. Dura is innervated by trigeminal nerve. The nociceptive receptors of the trigeminal nerve will be activated. The nociceptive receptors are activated, and that is why you have a headache, and it's mostly frontal, can be occipital. So frontal headache or head banging would be like person will bang his head like this, hand against the head like this, and say that I'm having a very severe headache, and the person will start vomiting. The vomiting part that we see will obviously be a projectile vomiting. Projectile vomiting is different from routine vomiting in a sense that it does not have nausea and will cause soiling of the clothes. Then we will have a false localizing sign. The false localizing sign will be sixth nerve palsy. You are all aware of the fact that the sixth nerve has the longest subarachnoid course. I'll repeat the statement once again. If we ask you that which cranial nerve has the overall longest subarachnoid course, the answer would be given as the sixth nerve. Do remember the fact that if I change the MCQ to which is the longest cranial nerve from the brain perspective, you see overall longest is vagus, that we all know. But if I just use the word intracranial course, longest intracranial course, then the answer will definitely change. So for sixth nerve, remember that this would be the one which will be having the longest subarachnoid course. Why I'm highlighting that is because in subarachnoid space CSF is there. So when the pressure in the brain rises, the CSF pressure rises. That is when the sixth nerve will get stretched. The disease is not in the sixth nerve. The nerve is getting stretched. Why? Because the pressure is high. So we call it a false localizing sign. Why? Because of the fact that the problem is not in the nerve, but it is stretching of the nerve. The clinical manifestations of sixth nerve palsy would be written as diplopia on looking laterally. Lateral rectus muscle is supplied by the sixth nerve, so that is why the diplopia would come on looking laterally. If he says which cranial nerve has the longest intracranial course, then it is the fourth nerve, the trochlear nerve. That's the thinnest nerve, and it has a dorsal origin, and it is having the longest intracranial course. On the other hand, overall longest is vagus. You know that, so there's no point of me writing it. And yes, which is the longest intraosseous course? Just verbally, intraosseous course would be valid for seventh nerve, right? I mean, the seventh nerve passes through the petrous part of the temporal bone. So sixth nerve palsy will definitely occur in patients of raised SAT. We call it a false localizing sign, reason I've explained to you. And then the fourth manifestation would be, or rather one of the reliable features, that the person will start going into drowsiness. He will be very sleepy, and then will go into stupor, from which he might actually progress into coma. So when you get these patients of raised SAP, what are you going to do? You're going to physically examine them, and on examination, the following features can be seen. You will be able to notice that the patient would be having a bradycardia. the blood pressure of this person would be elevated, so we call it Cushing reflex. You will next focus on the breathing part. You will notice that in these patients, when it comes to the breathing part, you will start having a hypoventilation in the patient because the respiratory center is malfunctioning. Due to hypoventilation, the carbon dioxide values will start accumulating in the patient, and then there's a possibility of apnea. Due to apnea, the carbon dioxide values might increase so critically, so high, more than 60, that this will stimulate the respiratory center to the patient to cause a few hyperventilation breaths. Please appreciate the fact that the most important stimulus for respiratory center is increase of carbon dioxide. So the highlighted or the increased carbon dioxide will stimulate the respiratory center, so he will hyperventilate, and then the same sequence will be obtained, hypoventilation and apnea. What I'm saying is that person would be having hypoventilation, apnea, hyperventilation. This will be repeated once again. There would be hypoventilation, there would be an apnea, and then once again I'll just represent in red also. The person will start hyperventilating for a few breaths, and then the same status quo is obtained. So you can see that I'm trying to teach you the fact that the person would be having what we call as Cheyne-Stokes breathing. In all patients of raised IST, we could be having hypoapnea and hyperventilation. Cheyne-Stokes breathing is also called as periodic breathing. This definitely indicates that you need to go in for interventions that I have explained to you. However, do remember, MCQ wise, Cheyne-Stokes breathing is also found in patients having congestive heart failure. Cheyne-Stokes breathing is also found in people who go to high altitude and end up with high altitude pulmonary edema. In fact, I would not like to specify pulmonary edema per se. I would like to specify acute mountain sickness. So high altitude sickness can contribute to Cheyne-Stokes breathing. AMS stands for mountain sickness, acute mountain sickness, and it is also encountered in raised IST. So let's quickly recap. Cheyne-Stokes breathing is not a characteristic breathing of raised IST. Why not characteristic? Because it's also seen in heart failure, it is seen in acute mountain sickness, and obviously the case that we're discussing. In the same patient, the breathing will then become erratic and you will start having breathing like this. So the person will deteriorate into what is called as Byard's breathing. Byard's breathing would be called as irregular breathing. Like in cardiology, I've taught you irregular pulse. In fact, I can just write it here. Irregular pulse is a feature that is always found in atrial fibrillation and multifocal atrial tachycardia. I'm talking about tachyarrhythmias here, not bradyarrhythmia. Otherwise, in bradyarrhythmias, obviously, we can be again having irregular pulse. But irregular pulse from the tachyarrhythmia perspective is atrial fibrillation and multifocal atrial tachycardia. Whereas when I say irregular breathing, that is gonna be Byard's breathing, which is more specific for raised IST. And if you don't manage him even now, then the breathing might even cease and he might take like no breaths. If you compare the previous Byard's breathing with the subsequent one that I have shown before you, you can notice the fact that he's doing like this. Few breaths, right? I'll repeat that again. What I'm teaching you in the last rhythm is called as agonal rhythm. This is just before the death of a person, just before a person dies, you will get what is called as agonal rhythm, which are very shallow breaths that it will give appearance as if the person is breathing, but it will not even be able to reach up to the terminal airway. So it's a very shallow breathing right before the death, right before the respiratory center begins to fire, and you will notice a person deteriorating like this before you, from Cheyne-Stokes to Byard's breathing to agonal rhythm. Other features that can be noticed apart from the breathing perspective in the patient can be a Hutchinson pupil. The Hutchinson pupil part I have also described with respect to intraparenchymal hemorrhage, because whichever side the bleeding is present, on that particular side the pupil will become dilated. So it will be a ipsilaterally dilated pupil on the side where the hemorrhage is present, brain hemorrhage is present. Here I can say that the ophthalmologist would have taught you that Hutchinson pupil is of 3 varieties. So I usually get this query that ophthalmologist has told us that on the same side the pupil will constrict. That is the initial stage. No, when the person initially has irritation of the oculomotor nerve, it causes the pupils to constrict. But in the same patient, in the later part, the pupil will become dilated. You can see the dilated pupil in this case. Why? Because there is paralysis of the nerve. So initially the nerve is irritated, so it will constrict. But when the nerve is totally kinked, it's totally stretched, it can't function. That is when the pupil will dilate. So Hutchinson pupil has these stages basically. But then I want you to remember that actually if they ask you to select one, it is a ipsilateral mid dilated pupil. It will tell you on whichever side the bleed is present. So the technical answer to Hutchinson pupil should be answered as what I just said, ipsilaterally dilated pupil. In fact, I've just modified the statement here slightly. This would be a ipsilaterally mid-dilated pupil with a poor reaction to light. Not a, I would not like to say that it is non-reactive to light, but it is relatively poorly reacting to light. At the same time, you will notice that the reflexes of this person will be relatively brisk. They can be elicited. Babinski sign can be present. Instead of Babinski sign, they can use alternative terms also, like Gordon sign. There are different methods, no? Babinski or Chaddock sign or Gordon sign. They are all, you can just remember BCG, Babinski, Chaddock, and Gordon sign. They basically all indicate corticospinal injury in the patient. Fundus examination will reveal papilledema. So if you encounter a multiple choice question where these kind of informations are given, you know the fact that you're dealing with a case of raised ISRT. I've just made you remember all these facts, though you know this from very basic classes. I would like to just go back to my previous slide and tell you that these three things together, bradycardia, hypertension, and Cheyne-Stokes breathing, only 1, 2, and 3, they are the ones which are also referred to as Cushing's triad. So one, we have Cushing's reflex. I've not written reflex because that is taught in physiology. You all know 1 plus 2. Bradycardia, hypertension is Cushing reflex. But the three things together is Cushing's triad. In fact, the funny question is Cushing's triad does not include, and the answer is Cushing's ulcer. You're all aware that Cushing's ulcer can develop in raised ISRT in the stomach. So Cushing's ulcer is not a part of Cushing's triad. Very straightforward a question, so not even writing it. You just need to remember Cushing's reflex is bradycardia with hypertension, and if you add Cheyne-Stokes breathing to it, it is a Cushing's triad. Do remember that Cheyne-Stokes breathing can also be seen in mountain sickness, so it's not very characteristic for persons of raised ISRT. These are the usual features of raised ISRT that you will encounter, and with pupils, I can say that you can get a lot of information. I mean, pupils of a person can give you a lot of information in the following sense. I can just make an entry of couple of them. You can add them extra in your notes. Though these fact features of raised ISRT are very simple, that I don't think so. You need to note down. But then the facts that I'm saying now, that I think are to be practiced by yourself. Like suppose he mentions that the person is having a bilateral small, but I'm not saying pinpoint, right? I'll talk about pinpoint also. He says bilateral small pupils which are reactive to light. Now suppose I was talking about pinpoint pupils, you know that we would be then talking about possibility of a pontine hemorrhage, or it could be drug overdosage. But if he says bilaterally small pupils which are reactive to light, then you will say that this could be possibly a metabolic encephalopathy. What do you mean by metabolic encephalopathy, guys? Metabolic encephalopathy could be due to ammonia, so it could be ammonia intoxication of fulminant hepatic failure, or it could be acute kidney injury causing uremic encephalopathy. So I'm not writing ammonia intoxication, I'm just writing fulminant hepatic failure, uremic encephalopathy, or I can say carbon dioxide narcosis. Carbon dioxide narcosis can be found in status systematicus and impending respiratory failure. So metabolic encephalopathy from internal medicine perspective would be like increase of ammonia, increase of urea, increase of carbon dioxide. But if you're gonna have question mentioning pinpoint pupils, we are just using this slide to remember some of the common things that we have studied in ophthalmology and neuro-ophthalmology also. So I'm just making you practice them again. Pinpoint pupils are always to be thought for one, opioid poisoning, and second is pontine hemorrhage. While I'm writing it, question to you guys: how would you clinically differentiate? I mean, obviously you can do a CT, and CT will pick up a hemorrhage in the form of hyperdensity. But clinically, I mean, both patients would be comatose and both patients would be non-responsive to your commands. Both would be having pinpoint pupils. So how would you differentiate? The differentiation can be made on the basis of body temperature. One, In opioid poisoning, you will always notice the fact that the body temperature will be reduced, whereas in pontine hemorrhage, patient is having hyperthermia with sweating, extensive hyperhidrosis. In opioid poisoning, there is respiratory depression, so respiratory rate will usually be given to be less than 10. But in pontine hemorrhage, the person will be rather having hyperventilation or the respiratory rate can be normal, either of the two. Hyperventilation or fast breathing could be explained by the Cheyne-Stokes breathing part. So, therefore, when you look at the vitals, especially the body temperature and the respiratory rate would give you an idea. Obviously, a CT would give a final conclusion. Then another feature I want you to remember is that patient always looks towards the side of the lesion whenever it is cortical stroke. Both eyes of the person, like both eyes would be looking towards one side. That could be like the whichever side the lesion is present. So patient always, in fact, I'll write the complete statement so that you can appreciate this better. Patient is looking towards the lesion. This is always a feature that is encountered in cortical stroke. Now, what happens in brainstem stroke is crossed. When I have taught you the brainstem stroke component in the earlier part of CNS, I've taught that there is always a crossed features. Crossed would mean that whichever side cranial palsy is, opposite side hemiplegia is there. So, patient always looks away from the lesion. One is look towards the lesion. Patient always looks away from the lesion when it comes to brainstem stroke. This is a good way to pick up the side of stroke if he puts this up in the question. Two more points that I want you to remember here are ocular dipping and ocular bobbing. Though you might say that I know this from ophthalmology, good, great if you know it. But if not, then do try to remember what I'm teaching you here for features of ocular bobbing and dipping that they have tend to ask. When you read the word ocular bobbing, I want you to remember that bobbing basically means that the downward movement of the eye is fast. So when I'm drawing like this, it basically means movement is fast. And when I'm drawing in dotted fashion, it means that the movement is slow. So please remember the fact I've highlighted that both eyes are going down fast and they're coming up slowly. So I can even call this a nystagmus, no? But instead of calling it nystagmus, what I'm saying is the word ocular bobbing that was specifically asked. Both eyes go down fast and then come up slowly. Then ocular bobbing, remember from the B alphabet. Ocular bobbing, remember from the B alphabet, is a feature that is encountered in basilar artery stroke. There are two things I want you to remember for ocular bobbing. One is that the downward movement is fast and the upward is slow, and B bobbing, B for basilar artery stroke. Now we will study about ocular dipping. In ocular dipping, the manifestations are ulta or reverse. That is, the downward movement is slow. The downward movement is slow and the upward movement is fast. And now we will remember in which condition would this be happening. So you will remember from D alphabet. This would be counted in patients having diffuse cortical anoxia. Like if a person has had a cardiac arrest will cut off all the circulation to the brain. And even if you give CPR and resuscitate the patient in the later stages because he suffered from brain damage, because let me say you started CPR after 4 minutes, irreversible damage will occur. That will result in ocular dipping, that is a diffuse cortical anoxia. So I would just like to highlight the terminologies here that would be useful to you. Let's do these three first, and then we'll look at looking towards or away from the lesion. One is I want you to remember that if he talks about pinpoint pupils, you know the diagnosis. Opioid poisoning and pontine hemorrhage, no big deal. If he says bilateral small pupils reactive to light, it could be metabolic encephalopathy. If you are having ipsilateral pupil which is showing a poor reaction to light, then it is Hutchinson pupil, which is indicating that the third nerve of one side is getting compressed. That means that there is a brain herniation process that is started, which is called as uncal herniation. What do you mean by uncal herniation? Is uncus is a word. Uncus as a word basically means midbrain. So you can see in the diagram, this is the uncus. This is the uncus. Okay, I'll use a different color so that I can highlight it. This is the uncus, this is the midbrain, this is moving downwards. So uncal herniation, UNCAL, uncal herniation basically means a midbrain herniation. It's a midbrain herniation downwards. So uncus is related to the third nerve always. Like you can see a bleed here, no? This is an extradural hemorrhage. It is putting pressure on the midbrain. And oculomotor nerve is present here. So I'm just putting the word 3 and 3 here. So oculomotor nerve is getting stretched. So because of the stretching of the third nerve, there would be a mid-dilated pupil developing in a patient. On the other hand, if the brain tissue is coming out of the skull, like there was a fracture of the skull and brain tissue is coming out of it, then it is called as transcalvarium. It is easier to remember calvarium because the word itself is very characteristic. Calvarium means skull, so transcalvarium. And if this part of the brain is pushed below the other, then it is called as cingulate herniation, or it is called as subfalcine herniation. In fact, most MCQs will use the word subfalcine or might even use the word cingulate herniation. One part of the brain getting midline shift to into the other. So let's recall. One is subfalcine, one is transcalvarial, that is skin is coming out, then is uncal herniation, and then I was saying transtentorium. So what do you mean by transtentorium is that either the midbrain or the pons, or as I come down the medulla gets compressed. So transtentorial herniation is dangerous because as you go down in the medulla or the vital centers, and transtentorial herniation will ultimately contribute to expiry of the patient. The controversy of which is the commonest one I've already mentioned. I would not like to call it a controversy. Actually, that question has two answers. That is, first is transtentorial and second is subfalcine herniation or a midline shift. So these are the clinical features that we see in persons having raised SAT, and the treatment part has already been discussed. Fundus examination will show a papilledema and CT scan, and if they ask you to compare, then CT is a better way to identify the presence of raised SAT in a patient. I repeat once again, imaging is superior to fundus because fundus would be dependent on the fundus examination would be dependent on the experience of the doctor. I don't want to rely on the doctor. I would like to rely on technology so that you can measure the ventricular size. So for diagnosis of raised SAT, it is better to do a imaging, and especially a CT would be sufficient to identify it. Now the problem that we can discuss subsequently is that in people who are having raised SAT, if proper treatment is not given, they can become brain dead. So I will now try to explain to you what do I mean by the word brain death per se. First of all, in a brain dead person, there is a possibility that there might be twitching of the thumb, or twitching of the fingers of the person, or there might be twitching of the toes noticed by the family member. So relative came to you. He said, sir, you were telling me my dad is brain dead and I noticed twitching of the toes. So you would tell him that spontaneous twitching, not gross motor movement, not an arm movement to any kind of a stimulus or like noxious stimulus. Like if I'm giving a noxious stimulus and there's a movement, then I can't say brain dead. But twitching of the toes is definitely a possibility in brain death. You see, for non-medico, if let me say you are doing a spinal reflex, you are checking knee jerk. Knee jerk may be elicited in a person of brain death. Knee jerk can be elicited in a person of brain death. So if a non-medico is gonna visualize or see you performing a knee jerk and sees the movement, he'll come to you, say, sir, how can it be brain death? So what you have to understand is that the meaning of the word brain death is brainstem death. I repeat the statement once again. The meaning of the word brain death is brainstem death. The vital centers which are present in the brainstem are gone. In brain death, even gross spontaneous movements would not occur. Even if you give painful noxious stimulus, you would not get any movement. Maybe a twitching may be present. So gross spontaneous movements are absent. But there is still a possibility that deep tendon reflexes at a spinal level may still be elicitable. And a spontaneous, or rather I would not like to use the word spontaneous, I'll be more comfortable just saying the word that twitching of the finger or twitching of the toes may be noticed in some cases, which might make a non-medico very restless. But you have to understand that the primary problem is brain death, brainstem death in brain death. So how are you gonna diagnose brain death is the objective of our discussion, and you need two doctors to be independently examining the patient. You first need to demonstrate that person is comatose with GCS less than 8. Now the prerequisite is that this coma should be irreversible. What I mean by the word irreversible coma, is that I have to rule out certain possibilities. Like, let me give you an example of reversible coma, like diabetic ketoacidosis. You can treat diabetic ketoacidosis person by giving an insulin drip. Similarly, you can treat a patient of hyperosmolar coma, diabetic with hyperosmolar coma, by again insulin drip. If a person is having uremic encephalopathy due to kidney injury, I can do hemodialysis. If a person is having fulminant hepatic failure and is having ammonia intoxication, I can definitely go in for liver dialysis. Yes, liver dialysis is also available now. You can go through the fulminant hepatic failure and liver chapter. I've talked about liver dialysis also available. And even if not, I still have lactulose, no? I still have neomycin, I still have rifaximin. So you can manage fulminant hepatic failure person. If he is having carbon dioxide narcosis, you can put him on ventilator. If a person is having a drug overdose, like if he is having opioid poisoning, then I can definitely go in for naloxone. And I need to rule out endocrine causes also. The endocrine cause that I need to rule out in the person can be like myxedema coma. Remember the fact that all these that I have written on the right hand side are examples of reversible coma. These you don't need to note down also. Why? Because these are very straightforward. No? Diabetic ketoacidosis is treatable. Myxedema coma is responsible to administration of liothyronine or levothyroxine. So you can treat the persons on the right hand side, and therefore what will I do? I should always check in for random blood sugar. I should always check in a KFT, perform a LFT, go in for ABG in the person. Then I would also like to check for if there's a possibility of drug overdoses, so I can do urine toxicology. That can help me in identifying a case of drug overdoses. If there is any suspicion, I can definitely do a TSH, T3, T4 so that I can evaluate any thyroid abnormality. And over and above this, though I'm not written, I would also like to do serum electrolytes, because hyponatremia and hypernatremia are also treatable causes. Because see, I've discussed this in electrolytes that if a person is having hyponatremia less than 125, you might have to give a correction with hypertonic saline. And if sodium is more than 160, then you can lower the sodium by giving 5% dextrose. So people who are having hypo and hypernatremia can also go into coma secondary to seizures. But if you treat the deficit of sodium, or if you treat the excess of sodium in the person, the person's sensorium can normalize. So it is important that testing should be done to demonstrate it is irreversible coma, and even imaging should be done to demonstrate it is irreversible coma, because if you demonstrate with the MRI or CT structural damage to the brainstem, if there is like a car crash and a person has had a structural damage to the brainstem, a bike accident, structural damage to brainstem, then I know the fact that yes, it is a irreversible coma in a person. So one of the prerequisites that I want you to understand for brain death is presence of irreversible coma. It's not coma, guys, it is irreversible coma. And how would you demonstrate irreversible coma? You would do these blood tests in the patient, and you would also go in for imaging. The imaging can be in the form of a CT, MRI, or whatever that is available, so that you can know that you have to demonstrate the structural damage to the brain parenchyma. And now what you're going to do next, once you have identified coma in the person, is to first check for the light reflex in the person. You will shine a torch in both eyes of the person. You will notice that there will be no response to the light reflex. The pupils of the patient will be fixed and will exhibit NR, means no reaction to light. Because the light reflex is absent, I'm going to check for the corneal reflex. To check for the corneal reflex, you can either use a wisp of cotton, or instead of wisp of cotton, you can also use a saline injection. You can push saline, and normally if something touches the cornea, we blink immediately. In this case, when you will do corneal reflex in a brain dead or a suspected brain death person, there will be absence of blinking bilaterally. The corneal reflex, he says, should be repeated twice, one with a wisp of cotton and second via saline injection, and both times the reflex should come as negative. Then you can take a wooden spatula. You can touch the posterior pharyngeal wall. You are checking for gag reflex, and the gag reflex of the person is also absent. If you don't have a wooden spatula, you can even do tracheal suctioning. Like you can use a suction catheter. You can do suctioning of the upper airway of the patient. Normally, if you do suctioning of the airway for more than 2 seconds, it causes cough. But in this case, there would be absent cough reflex present in a person. To elicit the gag reflex, we usually recommend to use a wooden spatula and touch the posterior pharyngeal wall. And for cough reflex, we can do trachea suctioning in the person. Either of the two can be done, but if both are done, it is great. Before I go forwards, I want to tell you that light reflex root values 2 and 3, it is mediated at the level of the midbrain. So if light reflex is absent in a person bilaterally, it tells me right away that the person's midbrain is damaged. Corneal reflex, the root value is 5.7 and it is mediated at the level of the pons. So I know immediately that the pons is damaged. Gag reflex and cuff reflex are related to ninth and the 10th nerve, and the ninth and the 10th nerves are related to the medulla. So you can see that the brainstem is composed up of the midbrain, the pons, and the medulla. And if I'm demonstrating damage to the midbrain, damage to the pons, damage to the medulla, it means that the person is going towards brain death. The next test that we will do in the person will be caloric stimulation test. Caloric stimulation test means that we will be doing irrigation of the ear canal with cold water and warm water. All of you know regarding cows, cold water causes nystagmus to the opposite side, warm water to the same side. But in this case, there will be no nystagmus from any side to any side. Why? Because the brainstem is dead. The impact of the frontal lobe or the gaze would not be there. So caloric stimulation test will fail to cause any kind of nystagmus. In fact, the technical term that is used sometimes in case of caloric stimulation test is oculovestibular reflex. After checking the oculovestibular reflex, oculo because we are checking for the nystagmus, and vestibular you can understand we are doing irrigation of the ear canal. So all oculovestibular reflex report will be negative. The next test in the person that will be performed is called as oculocephalic test. To explain this test, I can say like this. If I turn my head to right, look at my eyes, I can still turn my eyes towards my left. I turn my head to right, but I can turn my eyes towards left. If I turn my head to left, I can still turn my eyes to right. So our eyes can move independent of the head position. I repeat that again. Cranial number 3, 6 and 8. I repeat that again. 3, 6 and 8. They are interlinked among themselves that even if you turn your head to any side, still your eyes can move opposite to that direction. Like I'm turning my head to right, my eyes can still, I can still look at the camera. I can still look straight. So we are having integration of this neural circuit of 368, and therefore our eyes can move independent of the position of the head. They can move opposite to the position of the head, but in a brain dead person, whether you turn left, whether you turn right, eyes will look in one direction only. Like if you turn head to right side in a brain dead person, eyes will look towards the right only. They can't turn towards left. So oculocephalic reflex will also be absent. In fact, sometimes this oculocephalic reflex is also called as doll's eye reflex. That's actually a misnomer, but do remember the fact, like I can just put it like this. Doll is a non-living thing. So doll will only look in one direction. No, you turn the head of a doll to right, it will look to right. You turn the head of the doll downwards, it will look down. So it basically represents that the integration circuit 368 is not functioning anymore. Before doing oculocephalic test, you must always ensure that there is no C-SAN trauma. Cervical spine trauma is a contraindication to performance of a oculocephalic reflex. What I say next is the most important part of the discussion, so listen to this carefully. We are gonna do a apnea test to confirm brain death. Before doing an apnea test, before disconnecting the person from ventilator, I need to pre-oxygenate the person. So he recommends the fact that ideally, when you're doing this test, two doctors should be doing two independent examinations. Pre-oxygenate the patient with at least, let me say, as much of higher FiO2. I mean, if you can achieve a FiO2 of 100, that would be great. So pre-oxygenate the patient with 100% oxygen for a minimum duration of 10 minutes. And once you've done this, what you will do is, like, you will do a ABG to check for the PO2, and the PO2 should increase to something like 200 millimeters of mercury. Now the procedural part you can still forget, but I'm just trying to explain to you. I'm pre-oxygenating the patient for with 100% oxygen for 10 minutes. I want the PO2 to achieve a value of 200 milligrams. That is, I want to increase the PO2 from upper level 100 to 200. Dissolved oxygen is increased. Now the next step would be disconnect from the ventilator. The moment you will disconnect from the ventilator, you will watch for spontaneous breathing efforts. And in this person, what is happening is that the moment you disconnected, you expected that at least the person will gasp. At least he might do some agonal breathing. Here the person will be having absence of spontaneous breathing efforts. This tells you the fact that the brainstem is smashed. Brainstem is gone. So absence of spontaneous breathing efforts right away tell you the fact that in this person, the spontaneous drive of the pre-Botzinger complex, which is present in the medulla, is gone. If you will repeat the ABG subsequently, and this is inconsequential, you can just listen to me. The PCO2 of the person should be elevated to, because he's not breathing, no, more than 60, or at least a rise of more than 20 over the whatever is the pre-existing value, because you did ABG before, so you know the PCO2 value. Suppose it was 40, so it should either increase from 40 to 60 or should go more than 60. That tells you the fact that this carbon dioxide retention. And why are we doing this? We are doing this because carbon dioxide is the most potent stimulus for respiratory center, and if this potent stimulus will not work, nothing else will work. So apnea testing is also negative in this person. This is one of the important tests to demonstrate that yes, there is brain death. Then we can definitely go in for EEG. When we record the EEG of a brain dead person, we change the sensitivity of the electrodes. Normally, the electrodes are able to pick up electrical discharges even to the tune of 1 microvolt. But here we, to increase the sensitivity, we increase the voltage sensitivity to 2 microvolt. What I mean by voltage sensitivity increase to 2 microvolt is that now even smaller complexes will look bigger. Please appreciate the fact I am saying that now the smaller, by increasing the voltage sensor to 2 microvolt, it does not mean that I am reducing the sensitivity. It means that even if smaller discharges are present, they will look relatively bigger. So we are increasing the sensitivity of the electrodes, and when we look at the ECG, see what we get. If I zoom in, you will notice that it is almost baseline. It is a flat isoelectric line that you can notice in this person, and compare this with the EEG given superiorly, where you can still notice few erratic bursts coming at regular time. This that I'm showing before you has to be added by you in the epilepsy and EEG chapter. That's the homework for you guys. You need to, I have in the epilepsy and the EEG pattern, I have highlighted the various EEGs. I want you to add one to your vocabulary: burst suppression pattern. Burst suppression pattern would mean intermittent electrical discharges. Do not confuse this with periodic sharp wave complexes. Look at the ECG of periodic sharp wave complexes. Burst suppression pattern is a feature that is seen with cerebral anoxia. It is seen with hypoxic ischemic encephalopathy, and this is before brain death, right? Burst suppression pattern on EEG is a feature of cerebral anoxia, and the same person will deteriorate. And then you will be having what I've highlighted here, that is a flat isoelectric line. Flat isoelectric line will be demonstrated in the person. So the EEG of the person will evolve, and there would be a definitive, I can write here the theory part here, a flat isoelectric line. See, few bursts might still occur because the brain cortex is in the process of dying. So it will not always be a flat line. Some electrical discharges will be there. And we have deliberately increased the sensitivity of the EEG recording electrode so that we can record even smaller complexes, but still we are not getting any discharge. Another imaging that they recommend nowadays is MRA. I said we can do CT, we can do even MRA, in which there will be no flow in anterior and posterior circulation. The blood supply of the brain, I've explained in stroke chapter, so that is where you can read about the blood supply. There would be no blood supply in anterior posterior circulation. And then he also mentions regarding cerebral scintigraphy, which will show reduced activity of the cortex and of the brainstem. Imaging facilities may not be available everywhere, but the remaining features are definitely to be there. So let us just revise. What are you going to do for brain death? Because why are we studying brain death? Because raised SAT will ultimately contribute to brain death. So in a brain dead person, brainstem is dead, and how do you know? First prerequisite is irreversible coma. Irreversible coma. The person will definitely be brainstem death. There would be a gross spontaneous movement that would be absent in the person, but spontaneous reflexes can be there. Once you demonstrate the irreversible coma, you have to go for the following steps. That is, check for the light reflex, check for the corneal reflex, gag and the cough reflex, oculovestibular reflex, that is the caloric stimulation test. Oculocephalic reflex, eyes will look in same direction, not move like yours and mine. And then we come perform the apnea test in the person. If along with the 6 tests we can go in for any of these investigations, ideally all of them should be available, then we can say that the person is brain dead. You need 2 independent examinations. I'll highlight on this slide only. At least 2 doctors must certify presence of a brain death. So 2 doctors who are like ideally neurologists or belong to the organ transplantation team. Those 2 doctors should not belong to the organ transplantation team. Both of them should be independent of the organ transplantation team. So 2 doctors are to certify. That is the minimum guidelines. 2 doctors. to certify with two independent neurological examinations, because if they're filling up the performa simultaneously, then they can definitely be a bias. And unfortunately, we have had a brain death. So question to you guys: in a brain death patient, the relatives have agreed for organ donation. So question for you guys towards the end of this discussion is, uh, I mean, in a brain dead person, if you're planning an organ transplantation, like you harvesting liver or you harvesting lungs, one brain dead person can save how many lives? Then brain dead person, 8 lives can be saved. I mean, 8 lives can be saved by a brain dead person if the relatives have agreed for a organ donation. And what are the organs you can remove is, you can remove the heart, then you can obviously harvest the lungs, obviously the liver, kidneys. Yes, what else will you harvest, guys? I mean, you can harvest a lot of things, but what will be useful to save a life? Well, the entries that I've written is only 6, and I'm saying 8 lives saved. So what am I missing? No, I'm not missing eyes, guys. Eyes don't save a life, no. Eyes do not save a life. They save vision. Lungs are two, no. I mean, left and right, and same is the case with the kidneys also. So if you look at the entries here, it is heart, then lungs, liver, then the kidneys, pancreas, and the small intestine. So you definitely have 8 lives saved. Next is optional for you. You see, for cardiac transplantation, I can say cardiomyopathies are one of the important reasons. It could be dilated, restrictive. For lung transplantation, one of the important causes is idiopathic pulmonary fibrosis. Another one is COPD and cystic fibrosis. For liver transplantation, one of the leading causes for liver transplantation is hepatitis C induced cirrhosis of the liver. Not alcoholic cirrhosis first. The number one is hepatitis C induced cirrhosis. For kidney transplantation, it is diabetic nephropathy is the number one indication. In pancreatic transplantation, we go in for beta cell transplantation, right? Beta cell islets. We will take the donor beta cell islets and we will push them via the hepatic artery or the portal vein into the recipient. This would be done for type 1 diabetes mellitus. Apollo Delhi has started this. For type 1 diabetes, they're taking the beta cells and the beta cells from the donor, and then these beta cells will be injected into the portal vein of the recipient and would be given to a person of type 1 diabetes. And look at where the beta cells will go. They will go into the liver, not in the pancreas. They'll go to the liver where they will produce insulin. Small intestinal can be required for patients of like Crohn's disease, where they could be like extensive stricturing or fistula, or person could have had a short gut syndrome due to surgery, like a soldier got a bullet injury to the abdomen. So he had to be operated upon, and the large part of the gut is involved or has been removed. So small intestinal transplantation can be done. So in a brain dead person, 8 lives can be saved. And you very well know that heart and lung transplantation, they should occur as early as within 3 hours. I mean, you can read about organ transplantation from surgery, that heart and lung transplantation both should be done ideally within 3 hours of removal. Why I'm saying that is because you see, like Delhi Chennai flight is 3 hours. So even if you fly a heart from Chennai to Delhi or Delhi to Chennai, the heart would not make it. So if you're planning a flight from, let me say, Bangalore to Chennai or Ahmedabad to Chennai, is still possible. But Delhi to Chennai, I mean, we are a big and a broad country, so it may not be possible for long distance flight to be able to transfer an organ, because the time would be lapsed. In heart transplantation, we need to do it within 3 hours. And when you are transporting the organ, they have asked this question, that is UW solution, that is the organ will be transported in which solution? Then it would be University of Wisconsin solution, in which the organs would be like the organ will be perfused, right, and then transported from city A to city B. And they establish a green corridor so that the ambulance can rush. There should be no red lights in between to the hospital on time. The flight will get ability to take off first. Flight will give priority for landing first, so that the recipient can receive the organ which are mentioned here. And the reason why we have studied this is primarily to highlight the fact that brain death can definitely occur in patients of neurology, and you should know regarding criteria for brain death, how to identify raise SAT, and most importantly understand what are the interventions which are available to treat these patients, which I've explained to you. So thank you so much for your patience and hearing me out.